Endocarditis, also known as infective endocarditis, is a severe infection of the heart, its inner lining, primarily affecting older adults with the median age of 58. The condition has higher incidence in men than women, particularly those with structurally normal hearts. Key risk factors include IV drug use, poor dental hygiene, prosthetic heart valves, and a history of heart disease. The incidence of endocarditis have been rising since 1990, especially among the older population in the US, as well as countries like the UK and Germany. Pathophysiology. Endocarditis pathophysiology begins with the bacterial entrance into the bloodstream, escalates to significant effects on the heart and the body. Bacteria can enter the circulation by various routes, including dental treatments, skin diseases, and IV drug use. Pre-existing diseases such as rheumatic heart disease or prosthetic valves cause turbulent blood flow and damaged endothelium, rendering these areas vulnerable to bacterial infections. When the bacteria come into contact with the damaged valve, they attach to the surface and multiply, generating vegetation. Masses of bacteria might cause more harm to the valve. Vegetation can grow huge and break off, resulting in embolization, which occurs when blood clots travel to the organs and potentially cause difficulties. The body's immune response to the infection may worsen the situation, resulting in further inflammation and tissue damage to the valve. Risk factors. Modifiable risk factors. Poor dental hygiene. Bacteria from diseased gums may enter the bloodstream during dental operations. IV drug use. Sharing contaminated needles can transfer bacteria directly into the bloodstream. Recent invasive procedures. Any medical procedures that puncture the skin can temporarily increase the risk of germs entering the circulation. Non-modifiable risk factors. Congenital heart abnormalities. Abnormalities can risk of endocarditis due to alterations in blood flow. Bicuspid aortic valve. This particular heart defect is a significant risk factor even when there aren't any other contributing factors. Compared to the standard tricuspid aortic valve, the alternate structure, just 2 leaflets instead of 3, causes turbulent blood flow, damaging the valve lining and increasing susceptibility to bacterial colonization and infection development. Family history of heart valve disease. Family history raises endocarditis risk because the hereditary inclination to structural defects, such as aberrant valves, primarily sites of bacterial colonization and infection. Major signs and symptoms. Signs, a changed or new development of heart murmur. Murmur is an important finding on physical examination, indicating that the infection has damaged the heart valves. Splinter hemorrhages. Small linear streaking under the nails is considered a characteristic symptoms of endocarditis. Osler nodes, painful red nodes on the fingertips or palms, frequently associated with endocarditis. Symptoms. Fever is a common symptom, frequently changing and accompanied by chills. Fatigue, extreme exhaustion, or weakness resulting from the systemic infection. Unexplained weight loss. With endocarditis, loss of appetite resulting, and the resulting weight loss may follow. Diagnostic testing. Blood cultures. This is the most important test since it identifies the bacteria causing the infection by culturing microorganisms found in the circulation, which is a critical component of the diagnostic process. Transthoracic echocardiography, TTE, is the first imaging modality to look at for suspected valve abnormalities and vegetation, but the test is less sensitive than the transesophageal echocardiography, TEE. The TEE is often regarded as the gold standard. Provides more thorough images of the heart valves and the surrounding tissues, allowing for the detection of tiny vegetations and complications such as abscesses. Here are my references. Thank you.